think if you're going to, for the sake of time, to the next presenter, Professor Holm, Uhlig, from Professor of Pediatric Gastroenterology in the Translational Gastroenterology from Oxford University Hospital and consultant there. I think he's going to talk about the genomics of the inflammatory bowel disease. Yeah, thank you.
Thank you. It's great to see at this conference the impact that genomics has on patient care. And I want to illustrate some of these aspects in the field of inflammatory bowel disease. There are two main disorders, Crohn's disease and ulcerative colitis, that can affect patients at any stage of their life, typically between the 20s and the 40th year of age when the symptoms start. Now, the genetics of inflammatory bowel disease has been largely informed over the last 20 years by association studies, and there is really an increase in these numbers. More than 200 genetic loci have been identified, and these identified some of the mechanisms. So initially not too linked to autophagy and bacterial sensing. IL-23 receptor variants and is an inflammatory cytokine involved in the disease pathogenesis. So lesson number one, this genetic loci identified mechanisms. Number two, there are hundreds of them. It's a clear polygenic disorder. Subsequent studies have shown that there are quite differences in the disease susceptibility, where, as I mentioned, there are hundreds of loci as identified here. But if you do the same Manhattan plot for prognosis in Crohn's disease, then there are actually very, very, very few there, suggesting that the progression of disease and disease susceptibility, what causes disease in the first place, are very different mechanisms. Another lesson that came from these association studies is that these can inform treatment. I already mentioned the IL-23 receptor and antibodies blocking P40. The joint subunits for IL-12 and 23 are now in clinical practice. Similarly, this has informed, for instance, integrins, and this peak here is for the alpha-4 integrin, and vedolizumab is now similarly in clinical practice blocking the alpha-4 beta-7 integrin. With increasing use of genomics, it was possible to shift our knowledge from the more common variants to rare variants, and there is now sort of an increased understanding of the variants of 0.1%, and some of the variants again inform mechanism, for instance, like the IL-10 receptor variant, and IL-10 has been known for decades to be sort of a very relevant cytokine that keeps the control of the gastrointestinal tract. And this is a study largely informed with contribution of UK investigators, in particular the UK IBD Genetics Consortium. Now, another information from these studies is that there is a collective load of genetic variants, and that the collective load of ulcerative colitis variants and those of Crohn's disease variants is different, and you can calculate these polygenic scores. But as you see, statistically, this is highly significant, but there is still a large overlap. And among these hundreds of variants, it's still very much of a surprise that how many variants are shared between Crohn's disease and ulcerative colitis. But what these polygenic contributions, scores, allow us to do is to link this with more power to environmental factors. And this is a study just published that compared the genetic risk scores and lifestyle factors. and identified that if there are participants, even if they have high genetic risk scores and a more favorable lifestyle, this can reduce the risk for Crohn's disease and ulcerative colitis for 50%. So this is really informative and not so surprising, because we see a massive increase over the last 30 years of the incidence of Crohn's disease and ulcerative colitis, and that suggests there must be dramatic environmental factors, our lifestyle. Well, this study just shows that even in the presence of these risk factors, you can modify the risk by lifestyle factors, even if our overall westernized lifestyle in the UK is the same. So it's not about modern lifestyle per se, so there are specific factors in terms of smoking, drinking, diet that does affect. And interestingly enough, there are certain genetic factors that interact with genetic factors. So for instance, ATG16L1, a gene linked with autophagy, is interacting with smoking, and smoking does increase the inflammasome activation and is causing this genetic risk factor in ATG16L1 and causing a degradation of the molecule. And so there are certain risk factors that we understand from a functional point really well, and others not. For instance, it is not yet clear why smoking is protective in ulcerative colitis, whereas it's a clear risk factor in Crohn's disease. And so it's starting sort of to make sense. And the most important thing is now to understand the interactions between these polygenic risk factors and environmental factors. What is driving discovery in the last few years is the understanding of how genetic factors drive the expression levels, so EQTL studies, and how this plays a role in cellular ecosystems. And this is a study that informs the therapeutics. It's from Chris Buckley and Kali Dendro in Oxford. And it's a single-cell therapeutic atlas done in patients who received treatment, anti-TNF treatment, and then several hundred biopsies were taken throughout the gastrointestinal tract of patient. This allowed to construct a single-cell atlas. This allows us then to investigate cellular sources, who is producing TNF, who is responding to TNF, what other cytokines do play a role, and then to construct cellular ecosystems. And that's very important, because the gut is not just the gut. There are substructures, lymphoid follicles, inflammatory regions, and the inflammatory regions in lamina propria, in the crypt and in the villus are different, and this now informs of cellular ecosystems that we can stay in the tissue. And this allows us now to hypothesize which treatment options might play a role even if TNF is failing. Because this is a big question. We have these treatments, for instance, anti-TNF, that initially work in 60% of the patients, but over a lifetime, this ends up with about 40%. And a lot of patients have secondary non-response. And now, so these technologies allow us to understand whether, for instance, the progression with JAK inhibitors or IL-23 receptor targeting therapies would be the next in line. Now, what we have learned in the field of inflammatory bowel disease is that in addition to this group of patients that have this polygenic contribution, particular the adolescents, the young adults, where, as I mentioned, over 200 loci are contributing to the disease. There are now sort of, it was a few years ago, 50, it's now 100 orphan disorders that can present as Mendelian disorders, and they can present with inflammatory bowel disease. And that has changed the concept how we see inflammatory bowel disease. So in addition to this extreme complex network where hundreds of loci contribute in the epithelial setting and in the phagocytes and in lymphocytes or in regulatory element of the immune system, regulatory T cells, and this is affected by the microbiome. And in this extreme complex interaction networks, there are these rare disorders where, for instance, defects specifically in the phagocyte compartment, when phagocytes cannot degrade bacteria, can lead to upregulated inflammatory responses, or if IL-10 signaling is defective. And there is a non-response to this cytokine IL-10 that is produced by phagocytes or by regulatory T cells. And if these phagocytes cannot respond to these rebalancing immunoregulatory cytokine IL-10, this is causing intestinal inflammation with 100% penetrance at the age of 1 month, 2 months, or 3 months of age. Similarly, if regulatory T cells are not functional, this does cause intestinal inflammation in the majority of our patients. But then there are specific defects that affect the barrier function. And so there is, as we assume, a complete normal immune system, but barrier function is dysfunctional, and these can lead to intestinal inflammation. As a consequence, over the last 10 years, and this really started in 2009 when these IL-10 signaling defects were discovered. Over the last 10 to 15 years, there was a revolution in our field from association studies, targeted gene panel sequencing, the first study by Jochen Kammermeier at Great Ormond Street, then exome sequencing studies we have done, genome sequencing study, first study by Jenny Taylor in Oxford. And this has driven translational research in genetics, immunology, and this is now standard of care. What we now know is that over 100 genes have a penetrance higher than the polygenic variants. And these variants, as I mentioned, affects very largely the phagocyte compartment, regulatory T cells, effector T cells, but also increasingly we know that endothelial cells can be affected, epithelial cells, smooth muscle cells, fibroblasts that sit underneath the epithelium and are important for maintaining this epithelial barrier integrity, or even nervous cells. And the concept has shifted from a model where we thought, oh, this might be in one compartment. There are certain compartments, but then there are certain gene defects that act throughout, and this does have consequences for treatment. Now, what we wanted to do is we wanted to establish an integrated taxonomy of those disorders. So Chrissy Bolton in the lab and Sumit Pandey and Chris Milley, they identified what are sort of the parameters that are consistent and that determine these monogenic disorders, what are phenotypic and functional criteria. And in about 1/3 of the patient, the age of onset is under the age of 2 years, so exceptionally unusual. In another third, it's under 6 years of age. And if you see here the polygenic IBD cohort, this is still remarkable. Then there is another third where the age of onset as a median is in the range what we would expect. So it's not just the infantile onset, but it's enriched there. Then we see increasingly that there are sort of subgroups of patients that present, for instance, with certain immunodeficiencies, like chronic granulomatous disease, congenital neutropenia, Wiskott-Aldrich syndrome. And so there are a pattern of phenotypes that are emerging. We now learn that certain genetic conditions affect more the upper gastrointestinal tract, causing a duodenitis or an enteropathy, whereas others like IL-10 signaling defects and XIAP deficiency cause more defects in the lower gastrointestinal tract. And the concept that we learn is that if there are disorders that affect tolerance mechanisms, autoimmunity, this affects more the upper gastrointestinal tract, antimicrobial activity, and IL-10 dependent regulation that is more dominant in the lower gastrointestinal tract. Now, we see more and more diseases. Every year we identified several of those, and this has translational impact. This is a disorder we had identified 3 years ago, is SUC gain of function variants that cause autoinflammatory condition with colitis, dermatitis, arthritis, or B-cell lymphoma. Colleagues in China, Dali Li, made a mouse model as a knock-in of this genetic variant, and this mouse experiments identified that hematopoietic stem cell transplantation and SUC inhibitors would be beneficial. And within 2 years, this has translated into clinical care. The first patients have been treated successfully with hematopoietic stem cell transplantation as well as with SUC inhibitors. So it's huge therapeutic potential for translation. Similarly, we learn about these molecules not alone, but we need to take different evidence together. And this is an exemplar, a study we did jointly with Sophie Hamilton, where sort of in a consanguineous family, an PI3K 110 delta deficiency was identified in a family where the child developed pneumonia, colitis, CMV, enterocolitis, autoimmune thrombocytopenia. It was a frame shift variant, so a deleterious homozygous variant. And when we compare this deficiency with mouse models that develop intestinal inflammation as a spontaneous inflammation, and with the effects, the side effects of patients that were treated with PI3K delta inhibitors, where intestinal inflammation is found, as well as CMV colitis, we now know that this CMV colitis is not a consequence of immunosuppressive treatments that these patients have received, but it's a primary effect. So we need to take these multiple levels of evidence together and can learn about the effects. Another exemplar is we see a number of gain-of-function variants, for instance, in JAK1, causing intestinal inflammation as a disease-causing mechanism. Tofacitinib can resolve this inflammation, and tofacitinib is now moving into the clinical care of patients with ulcerative colitis and other JAK inhibitors in Crohn's disease as well. So these rare genetic variants inform on disease mechanisms that can drive inflammation. And what we like to understand is what is the big picture? What are sort of these mechanisms? How can we put these different, very variable genetic conditions into an framework? So what Chrissy did, she selected quantitative criteria, and one criterion is the penetrance of intestinal inflammation into high penetrance over 5% with a confidence interval of 90%, or moderate confidence. This excludes genetic variants that might present with intestinal inflammation, but it's not causative. Just think about cystic fibrosis. Cystic fibrosis is a common disease, 1 in 2,000, 1 in 2,500, and just by random chance, there will be, of course, a few patients with intestinal inflammation in a country like the UK. So we have to select those disorders where it's likely a causative mechanism that is above threshold. Then we use these gene variants where we have a high confidence of intestinal inflammation and looked for single-cell transcriptomics, and we can see these groups of disorders that are, for instance, present in stem cells or in the more mature enterocytes, those that are dominant in the fibroblasts, this large group of disorders that are expressed in monocytes or in neutrophils. There are these very, very selective group of patients who develop intestinal inflammation as a consequence of regulatory T-cell dysfunction. I mentioned FOXP3, but for instance CTLA4, ICOS, IL-2 receptor are expressed in this group as well. And then there is a group of patients that have a defect in lymphocyte development. If you put all this together, then this informs about certain pathways that are expressed, and this replicates the regulatory activity by FOXP3 cells, TGF-beta signaling, IL-10 signaling, but also these JAK-STAT signaling defects. We can start to see cytokine networks because these Tregs produce cytokines that act on monocytes. As I mentioned, IL-10 is produced. IL-10 then acts on a more broader range of cells. This controls TNF signaling or IL-1 signaling, and this TNF and IL-1 acts on a broad range of cells. Now, it's important to understand the mechanism, and now this needs to come into a clinical framework. And these monogenic forms of inflammatory bowel disease, jointly with the primary immunodeficiencies, are now part of the test repository in the test directory of the National Genomic framework of NHS England. We have set up, as part of the European Society of Pediatric Gastroenterology and Nutrition, and consensus. And subsequently, and that was very important, we set up with the British Society of Pediatric Gastroenterology, Hepatology and Nutrition, and the British Society of Gastroenterology, an genomic diagnosis and care coordination guideline that involved patients from 4 different patient organizations, that involved hematologists, immunologists. So it's really a multidisciplinary team approach that guides now this selection of patients who undergo treatment, who undergo diagnosis first, and if a diagnosis is made, then treatment options. So eligibility. As I mentioned, age of onset is the key factor, under the age of 2 in particular. Infection susceptibility or suspicion for a primary immunodeficiency, complex autoimmunity, congenital gut disorder, or early malignancy. These are the key factors. And in addition, therapy relevance. So if there is a patient who is very, very likely to undergo, for instance, a colectomy, and there are these factors available, then even an urgent genomic investigation should be done, because you don't want to have this patient who undergoes a colectomy and then you make a diagnosis of an hematopoietic defect, and you could have treated with an hematopoietic stem cell transplantation. Now, I want to give one exemplar, and this plays into the role. I think it's just a very remarkable case, that this is not only relevant in pediatrics, but in adult medicine as well. And as part of this guideline that we have set up, we listed a number of case reports that are informative. And in Oxford, we had a few years ago, as part of a research study, doing exome sequencing in over 500 patients with severe inflammatory bowel disease. And we established a diagnosis of a XIAP deficiency in an over 40-year-old patient who had 30 years of history of a very, very severe disease. So diagnosis of Crohn's disease made of the age of 11, and then subsequently, and these are the hospitalizations, hospitalization, operation, 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 and. This patient had an intestinal failure, because not only the large bowel was resected, but small bowel as well, required total parenteral nutrition for nearly 10 years. And then subsequently, the allogeneic hematopoietic stem cell transplantation was performed. Good. As clinician, we thought we resolved this, but the patient felt the quality of life was not as good, because still required total parenteral nutrition. And so subsequently, as a first in world, a small bowel transplant was performed. Now, we did see health economics of this one patient. Just see, it's millions of pounds that this one patient has received. So if we could prevent one of these patients, it would still require stem cell transplantation. But if you could see this cost compared to all the ones before, this is a minor fraction. This would probably be effective, at least for a large number of patients. To finalize, we have now mechanisms that inform specific treatments that are dependent on the genetic diagnosis, whether you can treat with IL-1 blocking, whether you can complement CTLA-4 and CTLA-4 deficiency by a fusion protein, XIAP deficiency. There is now initial evidence that IL-18 blocking might be sufficient. And in some disorders, even completely novel concepts emerge, like metabolic remodeling of phagocytes by glucose transporter. So it's not just this relatively strong allogeneic hematopoietic stem cell transplantation. There are a number of really mechanism-informed treatments that are informed by a genetic diagnosis. With this, I'd like to thank the members of my team, but here largely a number of colleagues in the UK of the IBD Bioresource, our networks. The NHS really supported a consortium in Southampton, London, Oxford, and Birmingham as a pilot trial to set out a network of MDTs. And I feel it's a great time to move this into clinical practice. Thank you.